Good afternoon. Wow, this is really loud. Welcome to the afternoon session on tips and tricks in the MERS department. My name is Michelle Lynn, and I thought I would spend a little time with you. I don't think I'm going to use the whole 3 hours to talk with you a little bit about some of the trade secrets we have. This talk is also entitled Style Points in Emergency Medicine. It's really kind of a way to share a lot of the common knowledge that we have as a specialty that really aren't presented in textbooks or in journals about how to do, right? How to make your day a lot more efficient by overcoming common hurdles that we all encounter in the emergency department. This talk kind of came about 5 years ago, and ACEP News had a column, you remember, called Tricks of the Trade, and so I used to write for like every week or every month or so, and after a while we'd start running out of tricks, I would start making up tricks, and so it's like, listen, I got to stop this, I can't be making up all these tricks. But for some reason at that time, blogs and Web 2.0 got really hot in medicine. So I created a little website to try to catalog all of these tricks because I think it's rather selfish of me to be able to hear of all these great tricks out there and not be able to share it with people out there. So I started cataloging all of these, and lo and behold, blog's about 3 years old now. Is that there's a whole repository of, think about 140, 150 tricks that I've gradually accumulated over these years. And so what I want to share with you are really the top tier ones that I think are really, really important on a practical level when we practice in the emergency department. So hopefully, as much as we can, it's a bit of a big room, but if you have any suggestions, comments, alternatives to the tricks that I present to you, I would love to hear it. Because this talk really is a compilation of all of our collective tricks that we know that work in the ED. So just to start off, we are in the front lines of medical care, and really speed and efficiency, and really more so than any other specialty, is so critical to us. So a lot of these tricks really are to improve your day-to-day functionality. So we as a specialty are probably the most creative folks out there. So I call us like the MacGyvers of medicine. So if you have some tricks, I know you guys do, because every time I give this talk, I come away with as much as you take out of here. So what I'm going to do is go through some rapid-fire cases, just to kind of put us in the same mental mindset of cases that we commonly encounter, specifically on wound care, ortho stuff, pediatrics. I know tomorrow you'll have a whole day on it, but there are some really cool tips specifically for pediatrics, head and neck. The physical exam, no, it's not dead. There are some great physical exam tips to remember. Airway pearls, vascular access, miscellaneous, and then the common thing that binds us all together are olfactory disasters in your ED and how to manage them. So that's always a great closer because that's some really key practical tips that save you and all your patients around you. So let's start off with wound care. This is a 270-year-old woman. Comes in with an arm laceration. Right? You look at this laceration, you just look at it and it starts peeling away. You're like, you don't even have to touch it, and it just gets more and more macerated. But first of all, let's start with the simple question: how long is this lac? Right? We got to document the length of our wounds. How do you measure? Do you just eyeball it? You're like, 10 centimeters. Or do you guys actually have a ruler to come measure? I personally hate to carry things in my pocket. As much as possible, I try not to carry rulers around. So what do you have around you that can help you measure things? Well, you have your quote-unquote handy ruler, right? So you measure parts of your hand. So I know personally my left hand can reach a maximum of 20 centimeters. My pinky at its DIP on the left hand is exactly 1 centimeter, and my left palm is exactly 8 centimeters. And so knowing these parameters, I can get a much more accurate measurement of whatever I see, a laceration, an abscess, an area of cellulitis. It's a great way of giving you some benchmarks to measure things more accurately. Because we as a specialty in emergency medicine are known to be poor estimators of length. So also, alternatively, what you can do is, your stethoscope has that silver bar on it. You can just get like a little permanent marker and just tick off little 1 centimeter marks, because generally you will have your stethoscope with you at all times. Either way. All right, looking back at this laceration, how would you close this wound? Right? Do you just go, I'm so sorry, I'm going to put some Zeroform on it and let it heal by secondary intention? Option B, I'm going to try to put some steri strips and then go, I'm sorry, then I'm going to try to let it heal on its own. Option C, you're going to be aggressive and try to do some suturing, right? Probably not going to work so well. How would you fix this? Right? It's a common challenge. This is the 270-year-old woman on steroids for, who knows whatever reason, and if you get any needle near this, it's just going to tear right through. Right? So the solution I found was a great article in Journal of Emergency Medicine last year, 2011, and it says, well, why don't you make the skin thicker? So what you can do is you pull steri strips, and you basically create a thicker skin width. And when you pull them together, then you suture through the steri strips to hold it together. Right? Now, one variation of this trick, I don't think this is the perfect answer to this, because what you're going to end up with are little scalloped, right, areas of wound closure, right? So you're going to get a little bit extra tension where the steri strips and sutures are. So why don't you spread this out a little bit more, if possible, like in a semi-linear laceration? Why don't you put the steri strips parallel to the wound edges, right? So you bring it together. It won't actually have to cross the wound barrier. Just create a thicker skin first on either side, and then suture the steri strips together. Right, so see what you think on each one. Apparently for a very irregularly shaped laceration, I think option A would be better. But if it's a fairly linear one, try to use the steri strips and then suture through it. So I think you have two alternatives here that you can try for the really thin skin. Great, so how about lacerations near the upper eyelid? Right, this is such a simple laceration. Tissue adhesives will be great for this. But you have the dreaded complication of, well, what if glue falls in the eye? So what are some tricks you can do so that the tissue adhesive doesn't actually fall into the eyelid space but goes elsewhere? Right? So if you guys think of anything, I think a lot of you guys already do this, which is that Dermabond and other tissue adhesives, they're impermeable to petroleum jelly, right? They're not going to roll past it. So what you can do is actually put a layer of petroleum jelly or Neosporin, bacitracin, whatever you got, entirely in the eyelashes, just in case the tissue adhesive decides to roll in that direction. Alternatively, why don't you use gravity in your favor? Right? So if it's on the upper eyelid, tilt the bed upside down, put them in Trendelenburg so that if it were to roll anywhere, it goes in the eyebrow rather than the eyelashes. And then conversely, if it's in their lower eyelid, tilt them in reverse Trendelenburg, and then it'll roll down towards their cheek if it decides to roll anywhere. Right? So just don't be afraid to use the angle of the bed to do what the tissue adhesive should do. Here's an example of the petroleum-based jelly as a barrier. Right? You can put it in the eyelid, and then you can very comfortably glue the wound back in place. However, one of my probably top 5 favorite tricks that's really kind of taken hold, so much so that really in our residency program, the residents think this is a standard of care for all tissue adhesive closure, is this trick. Came from my friend Hagop in Fresno Community Center. Move the mouse out of the way. What you can see here is, well, what do we have in our ED? We have these transparent Tegaderm adhesives, right? So why don't we fold it in half, cut out a semicircle so that when you open it, it looks like an oval, right? And this would sit right over the laceration area. And then once it's nice and dry, then you put the appropriate layers of the tissue adhesive. And then right after you apply it, it's already starting to thicken up, right? The viscosity is already increasing. So as soon as you apply it, just peel off the tape. And what you have is this really nice, round, well-circumscribed, well-demarcated area of your tissue adhesive where you exactly want it to be and nowhere else. I think it looks much nicer this way rather than like an abstract painting over a wound. And this also really ensures that your glue doesn't go anywhere you don't want it to go. As a tip, by the way, you really don't need to you don't need to tack this entire tape down to the face. All you need is this periphery right here, really secured to the skin, and that's it. All the rest can kind of flange up a bit, right? Then you paint it, and it's easy to pull off. So see what you think of this trick. This has really been a lifesaver, especially for wounds in the face, especially in kids, right, where you're going to move around a bit and you don't know exactly where the tissue adhesive is going to go. this really saves you any potential errors. And then if you get really fancy, right, if the kid asks for, like, well, can I have a rectangle? You're like, you can have a rectangle. Or can I have a star? You know, that might be a little harder, but you can really mix and match the shapes that you want. You can do like a lightning bolt for Harry Potter. Who knows? So here's some examples. Just as an example of a kid kind of fast asleep. You put the tape on, you keep it super dry, and then you're able to glue this on. Just an example. All right, what are other uses for tissue adhesives? This is such a great tool to have in your ED. Right, so what have you used it for that's really on the non-traditional end? Well, here's one. Have you seen, this kind of grosses me out a little bit, but you know when people's nails come off in their entirety and they bring it into you and you're like, that's disgusting. But you know you can reimplant it, right? You should reimplant it so that the eponychial fold doesn't seal down completely shut, preventing a new nail from coming in, right? But when you slide it in, how do you secure it in place? A lot of the textbooks, the procedural textbooks, actually say to drive a needle through either side and tack it down. It seems a bit archaic, and that you're creating new holes which weren't there already. So why don't you just glue it down? This is a great tip from Dr. Carr over in Toronto. So he sent some photos over. It works amazingly well. It just has to be a very dry field on top of the nail before you do this, right? You can do this for fingernails. You can do this recently we did in our ED. You can do it for toenails, right? Just slide it back in, glue it on. It seems so much more elegant that way, right? What do you notice from this picture? Every time I see this picture, I don't know why, I'm bothered by this one long hair. I don't know why. I didn't know how to Photoshop that out. But anyway, that bothers me a little bit. All right, what if you're missing the nail, right? Sometimes it just gets yanked off, left at the seam. You still want to try to preserve that eponychial fold. What do you put in between? I've heard some people put some Xeroform in there, but it's kind of a little squishy. It doesn't quite all the way set in nicely. You want something maybe a little bit more rigid? My mic is off. I feel naked. Hold on, technical difficulties. Discuss amongst yourselves. Am I moving around too much? No, you're doing great. Keeping things exciting. Try not move around. There you go. Okay. I'm back. So what do you do if you're missing the nail, right? You want something a little bit more rigid, more so than a Xeroform piece. So what you can actually do, this came from my plastic surgeon colleagues. They go, well, what do you have with you in your ED? Well, you have suture material, right? It's made of this kind of aluminum-y, semi-rigid material, right? You basically cut one out the shape of the nail, and then you slide it in. And it stays in, actually secured in very snugly, right? So you slide it in, it's the right thickness, it's the right degree of bendability. It's perfect. So you can also glue that in place if you'd like. All right, what are other uses of this? Have you guys seen in wounds that are slightly under tension, technically tissue adhesives are contraindicated, right? However, there's always that star that says, well, if you can take the tension off a little bit, you can still use tissue adhesives, and that's where this comes into play. So you can actually use Steri-Strips to take off some of the tension, and then you shellac the whole thing down. And I do want to warn you, when you do this, try to put the tissue adhesives over these ends as well, because I think it is part of human nature to want to pick at these things, right? When they kind of come up a little bit and they're like, dit, 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 dit. So no. So go ahead and just tape everything down, and I give a little bit of extra dots of glue right on the edges so that people won't pick them off, right? Similar with this photo here, they are so going to pick at this in the day 2 or 3. So try to cut the tails of the Steri-Strips a little shorter, and then glue everything down. And I find it just anecdotally that wounds using Steri-Strips actually have a little bit more cosmetic, better outcome. So what I do is when I actually do Steri-Strips over the site, and I glue everything down. It's the wound edges just come together a little bit more predictably well than just plain tissue adhesives alone. Is anyone using this combo trick? Right, with Steri-Strips, perfect. And tissue adhesives, I think it's a great combination to have. It brings the tension off if there's any. So I do encourage you to try this if you haven't already. Well, what about other adjuncts? So you have Steri-Strips with glue. What else can you do? Well, you could also use sutures plus glue, right? Because specifically in pediatric patients or patients you think are marginally housed who may or may not come back for suture removal, think about using absorbable sutures to take off that tension of the wound. Right? So you can use various types of absorbable sutures. So in the picture on the left, you can see it's right on the patient's chin, so potentially it may splay open with the tissue adhesives. So there's just 2 absorbables put in, and then tissue adhesives to cover it up, right? And versus the picture on the right, as a woman, the laceration is right on the line of the wrinkle. And so when you look at it, if you were to glue it as it were, it would be a little bit inverted, and cosmetically it wouldn't look as great, right? So you want to at least flatten or evert the wound a little bit with those sutures, absorbable, and then you can glue everything down. Right? So think about mixing and matching. Tissue adhesives, wounds under tension, they're not actually mutually exclusive. You could try to use them in the right scenarios. So this brings up the question, what kind of absorbable sutures should you use? Right? I think everyone's got a slightly different array of sutures in your ED, but here's just a general review of the sutures that are out there. Right? The classic initial one that's out there is the surgical gut. Very few people use this now because it's got a lot of tissue reactivity, but generally effective wound support's 8 to 9 days, lasts 30 days. There's chromic, right, which I think a lot of us have, and a lot of our plastic surgeons are starting to use this as primary sutures for wound closures of the face and of the hands. So just realize that the effective wound support is up to about 3 weeks, usually more in the order of 2 weeks, goes away after about 3 months. Skipping on down to the 4th one, there's also Vicryl, right? Also about 21 days, about 3 weeks, 90 days to go away. And then there's Vicryl Rapide, which is great, goes away in 10 days. Now, recently, I have no disclosures on any of this stuff, but we recently in our ED purchased the fast absorbing gut. Has anyone used these at all? Any experience with these? It came out, yeah, perfect. So they just came out like 2 years ago, maybe, at least in our ED. And they're really friable, so they're very prone to breaking. So just be very careful because they're already pre-treated to degrade much faster than regular gut. Right? So look at this effective wound support, 5 to 7 days. That's perfect, right, for the face, for the shallow lip laceration. So I use this a lot. If you're going to be doing tissue adhesives, I actually use the fast absorbing gut underneath, and then I glue it down. Okay, moving on to other wound care issues. We have a man that crashes his motorcycle, injures his hand. You take a look at this. This is a crush injury, right? You got some gravel in there. You got some dirt. You're pretty sure there's going to be some foreign bodies in there. How would you check for non-radio-opaque foreign bodies? So you get an X-ray, no fractures, no radio-opaque foreign bodies like glass. But what else? How would you check to see? Would you dig into each one and look around more? Do you CT this? It seems a bit of an overkill. Right? How do you guys do this? Well, this is a trick I actually saw one of our residents doing. I was just walking by, and I turned around, and she had the ultrasound machine with her at the bedside, and I didn't know you could do this, but she dunked the transducer probe in like a big bucket of water. And I didn't even know it's water, it's safe for water. I'm like, what are you doing? You just dunked like a $30,000 probe in the water. And she was like, what's going on? And she seemed, unfazed by this. And I'm like, what are you doing? And she says, this is the ultrasound water bath technique. First of all, this sounds like one of our Vegas spa treatments. And I'm like, oh, that sounds lovely. But the ultrasound water bath technique is actually a means for looking for foreign bodies using ultrasound. And the idea is, the transducer, when it sits right up against the skin, is not that great at picking up structures that are right abutting the transducer probe, right? So you need a little bit of a bump. You need a little bit of space so you can look through the initial 1 inch or so. So you can put on, an inch of gel and then lightly rest it on top. Or I've seen some people rest a bag of 250 cc saline bag right on top and then transduce through that, because water, as you know, it transmits ultrasound sound very well. Right? Kind of like, when you're ultrasounding for ascites in the ultrasound workshop, you can see through it. It's extremely black, anechoic, and it looks right through it. But in this person with a horrible, crush injury to the hand, they're probably not going to like the fact that there's a bag sitting on it. So what we can do is just dunk it in the water, right? And then you just rest the probe about an inch away from the hand or the skin that you're looking at. And then you're reading it like a regular ultrasound, looking for foreign bodies. So this is just an example of a positive finding. You can see here's the layer of water on top, the black. Here's the edge of the skin. Foreign bodies, dense foreign bodies are hyperechoic or bright white. casting a shadow. And so now you know, I'm going to need to look a little bit more here to try to clear this foreign body out. But given that foreign bodies are such a big medical legal risk in our system, I think this is a great adjunct to help you look for that occult foreign body. So think about the ultrasound water bath technique. Okay, so now you found, let's say you got all the foreign bodies out of there. Now you want to work on irrigation and potentially suturing of some lacerations of the hand. How do you achieve pain control for the hand? Right? It's got distals everywhere. You want to be putting lidocaine in every area. So then we start thinking of, it can't really do a digit block because it's more of the hand, but the idea is you want to start a regional block. So we know of classically, that the wrist blocks of the hand, the median, the radial, the ulnar nerves, you can blindly inject in the volar part of your wrist, right? So I think that's a great tool to have. But given in the modern age now of ultrasound in your arsenal, why don't we use it and actually look exactly where your anesthetic is going? I think this is such a cool procedure if you guys haven't done this. And I find that our residents are so much more facile than this compared to the faculty. But it's called a fun block. I guess it's only fun if it works for you. Otherwise, it's very frustrating. But a fun block is a 4-arm, ultrasound-guided nerve block. And it makes sense. I'm like, why have we been doing this blindly? This makes so much more sense. And the idea is you want to inject not at the volar wrist, but about a proximal third of the forearm up. It's pretty high up. But at that point, all of your nerves are starting to come together, just slowly starting to come together. They're starting to kind of wedge into a single point. And what you're doing there is you're looking for nerve bundles. Nerves, so vessels are black on ultrasound. Nerves are white, right? They're bundles. And they usually have a little bit of a bright white ring to them. It's the nerve sheath, right? So let's take a look at what some of these look like. This is just a still shot of the ulnar, the median, and the radial nerve in this patient. And I can tell you this side is right here is the ulnar side of the patient. This side is the radial side. Here is the bone. You can see bright white is the ulnar bone. And so the ulnar and the radial nerves are paired with their arteries normally. So here's the nerve. Here's the artery. Here, median nerve I find is the easiest one to identify because it's sitting right on top of a fascial plane and a sea of hypoechoic or black muscle belly. Right? It's just the only bright white thing that's going to pop up. So here are these nerves. Here's the radial nerve sitting next to the radial artery. All right, so this injection method, it's not so much like the classic method. When you do an IJ line or a central line, you're putting the needle in short axis view, right? This is a little bit different in that you want to go in plane with the transducer probe. So you're coming from the side. You need a fairly long needle to do this. Coming in from the side, and in this case, it's coming from the left of the picture. This bright white is the needle coming in, and all you do is rest the edge of this tip of the needle really close. You don't want to do an intraneural block. You want to do a perineural block. And as soon as you inject, you know you're in the right spot because as soon as you inject, what happens is the anesthetic, which is black, all of a sudden it will dissect through the planes there, and it will just all of a sudden form a nice black halo around the nerve. Right? It'll push all the soft tissue away and goes, whoop, and then the lidocaine, bupivacaine will just surround the entire nerve sheath. And then you get great anesthesia. I mean, it's something to be said about seeing exactly where you're going. So if you haven't tried this technique, it is fantastic. You can actually get probably sometimes 2 up to 3 of the nerves all with one needle because they're all fairly close by. So think about this for good regional anesthesia of the hand. Now, while you're doing this, you realize that you didn't take off the ring of his finger, which is getting a little bit more and more swollen, and you realize, I should have taken the ring off. It's now getting, the finger's too sausage digit, and I can't pull the ring off. I'm going to need to take this ring off because also there's a lac under there I got to fix. So how do you get this ring off? And I think if you use a ring cutter, that's kind of cheating. All right, so how do you get a ring off? I think the procedure books, you know how they tell you about that elegant trick about this lubrication and string trick? You guys heard of this? So you start distally with a piece of string, and then you slowly coil the string around your finger proximally to kind of quote-unquote squeeze the edema out towards you. And then you slide the piece of string under the ring, and then you slowly undo the coil and the ring slowly comes off over that string. You guys heard about this trick, right? So I think this is it makes sense when you talk about it mechanistically. You're like, oh yeah, that should work. But I find that it rarely actually works because you got to get the ring over the finger and now plus the string, which is on top of it. And so I have a hard time getting this off. And when I gave this talk, there's a guy, I believe it was Dr. Chavez, who said, you know what, in my 20 years of practice, I have never had to cut a ring finger off, and I have never had to do that string thing, which is just crazy. Like, why are we trying to make it over elegant? You just want to get the edema down to the finger. So start with a tourniquet, start at the tip of the finger, wrap it pretty tight. You might need a digit block for this. Wrap it very, very tight. Wrap the ring. I mean, why do you want to go under the ring? Just wrap the ring in there, and then what you'll be left with is a tail of the tourniquet, and then either you can hold it in place or have the patient hold it in place. 10 minutes, go away, come back, and you put a little lube on it, it comes right off, right? I mean, there's no need for this string coil craziness. And he goes, in 20 years, he's never had to cut a ring, and this always works for him. And so when I wrote this online on the website, little did I know that people Googled, tricks of the trade while they're on shift. And so Dr. Grisby, who used to be a Stanford resident who trained with me at San Francisco General, she goes, I saw your tricks while I was on shift, and so I just tried it. And these are her photos. So she wrapped it, 10 minutes, boom, came right off. And so she sent me these photos as a nice kind of way of feedback, but this really does seem to work. I personally haven't tried it yet, but I'm waiting for the next stuck ring to kind of have at this. So let me know what you guys think of this. Has anyone used this trick at all? Does that seem to work for you every time, right? It's like, it seems so easy. Apparently, how long do you leave the tourniquet on for? Yeah, so perfect. So you leave it on for about 10 minutes and you elevate the hand. That's perfect. Any other ring tricks out there so you don't have to cut them? I find that that's the most consistent one that people vouch for. So I think worth giving it a try. Great. Ooh, sorry about that. So the ring has come off, and you find the fourth finger laceration, and now it really starts to ooze, right? Because you've basically let go of all that pressure. It's now starting to ooze. So how can you get better hemostasis short of, you've already tried pressure for 10 minutes, and you take it off, and it's still oozing. What's your next trick? Well, the ring actually is a tip-off, right? There's 2 digital arteries to each finger. There's one on the radial, one on the ulnar side. So by external compression, you can get good hemostasis, kind of like what the ring did. So how do you create basically a ring effect? And you shouldn't put the ring back on, right? How can you create this ring effect that you can easily take off again? So what I do is there's a thing called a ring glove that you can make. So you grab basically a regular glove, you cut off a fingertip, or one finger of the glove, you put it on yourself, snip a tiny hole at the tip, and then roll it proximally towards you. And it creates basically a glove finger, right? And then you can take it off yourself, and then you put it on the patient's finger, and it basically creates a tourniqueted ring over that finger, over that digit, right? You can do that. I find that sometimes it still oozes after that, and the common pitfalls are that, you should probably use a small glove, right? Or create a smaller hole at the tip so that when you roll it back proximally, it creates a tighter seal, right? A variation of this trick I've heard is, for some reason, if you want to keep a very sterile field over the rest of the hand, is you can actually grab a sterile glove, right, fitted to the patient. So, assuming you have good pain control, slide the sterile glove over the patient, right? Snip a hole over the digit that's affected, and then roll it proximally. And what you have is an exposed digit that you want to work on with an entirely sterile field with good hemostasis, right? So you can try either of those things. I tend to like this glove ring technique because once you have blood on the hand, it gets a little sticky to get that sterile glove over. But, I think it's just nice to know of different options for this. Yeah. That's a fantastic point. I hadn't heard of that. So the point is, for going back to the topic of foreign bodies in wounds, let's say you do pop out like a gravelly glass-looking type thing, and you're like, I wonder if there's more in there. What you can do, it sounds like, is you can tape it onto an index card next to the patient's hand and have the tech shoot a picture through both so that you know kind of the density of the foreign body that you're looking for. So I really like that idea. Thank you for the tip. Because you know that everything's are of different densities, and I think anything to help frame the reference point for the radiologist, I think is very helpful. All right, let's continue on with a man who crashes his motorcycle and injured his hand. Let's say you got the foreign body out, you have good hemostasis, you close the lac, the ring is intact. Our residents, I find, they do all of this great work to optimize cosmetic repair, and then they slap this crooked 4x4 piece of gauze on there that barely hangs on, and it's just like so anticlimactic. It's just like you need more style points for the end there. So I said, bandage it up really nicely for them. It takes like an extra minute, but it does go a long way. So there's a thing called cotton tubular gauzes. Do you guys have this in your ED? They're kind of very stretchy. They look like finger tubes, right? But you kind of need an applicator for it. And this is an example of a finger applicator. I don't know how long these things last in your ED, but anything that's not bolted to the wall, it disappears in about 2 seconds flat. So we have tons of these rolls and none of these finger applicators. So you're like, well, how can we put this on? It seems such a waste, because I think it looks really beautiful when you use the gauzes. So one of our nurse practitioners, who I think she's like so famous for this, is called the DigiSpec, right? What do we have in our ED? We have specula everywhere. They're everywhere. Maybe not the VA, but like everywhere else. So we have, let's take a look at this. So you can create your own finger applicator, and poor Dr. Ye here, who was always in the wrong place at the wrong time, agreed to be a demo. He's our San Francisco Fire Department medical director. And you grab a pelvic specula, you load up the cotton tubular gauze, you cut like maybe 2 feet worth to start with, you load it up entirely, you can lock it into place, you can use small, medium, large, right? People with small fingers, fat fingers, things that already have gauze on them. Use the right size. You put 3 to 5 layers of the tubular gauze on, and make sure that when you get to the tip of the finger, you rotate it a couple of times so that it locks the gauze in place so it won't basically slide off as soon as they get home. All right, so this is a work in progress. So you put, and you make sure you leave a very long tail at the end of this, and what this does is it allows you to secure it to the wrist. All right, so you create 2 little tails, scissor it longitudinally, and you have a nice little tie there. Right, so you can use, these tubular gauzes are fantastic. You just need the applicator, and now everyone has an applicator, right, pelvic speculum. Just some caveats on this, so we use it for all the time now, is that there are some case reports of digital necrosis, right, because you are putting a circumferential bandage over the wound. So in these few cases, this is what happened. So a couple of cases, a patient has baseline neuropathy of the fingers. So they can't tell you if there's pain out of proportion. So maybe you shouldn't put these gauzes on them, right? So avoid it in digital neuropathies. Another case is that there's 2 types of tubular gauzes. There's one that breathes really well. You could stretch it. It's cotton. And there's another one that's a little bit more elastic and mesh-like. And it barely has any give. So don't use the one that's elastic-based. Right? Use the one, you can do it. Just stretch it. It can actually fit over your head. That's how stretchy it should be. All right, so use the cotton tubular gauze. And then there was one case that got digital necrosis. It's because you know how we twisted it when it got to the very end of the fingertip? Well, in this one case, they twisted it at every joint level, kind of like little sausage links. I'm like, what are you doing? Don't only twist it, the gauze, once you're past the tip of the finger. Other than that, this is a great, very safe way of applying a really nice dressing to finger wounds. Okay, we're still on wound care. How do you avoid, you get this messy scalp lac, all this blood is starting to mat in there. How do you avoid missing a second scalp laceration? Right, look at all that hair. How am I going to see anything? And classically, if you're fortunate enough to be in the main resuscitation bay, right, where you get these really bright lights to help you, I think you can find the majority of these. But what if you're in a regular patient examination room? It's like regular overhead lighting. How do you get good lighting? Right? You know how, I don't know if you guys still have this. I think every time I give this talk, more and more people are trending away from the tungsten light bulbs. You know, those really cheap flashlight pen things you have. they're all trending towards LED light sources, right? Light-emitting diode light sources. And is that a light-emitting diode? What is that? Oh, Lordy. So there's a lot of different light sources out there, and they're increasingly, so they're getting cheaper and cheaper every year I give this talk. So you can, there's some keychain ones you can do. There's also, there's some pen lights. And so this is one, I have no proprietary disclosure or anything with this. If they want to give me money, I'm happy to receive it. But they're anywhere from like $8. I saw on Amazon they were on sale for like $25 recently, so a bunch of our residents got it. And I want to show you, so I actually brought it. And hopefully I didn't, oh, here it is. It's just a pen light. These take 2 AAA batteries. I haven't had to recharge this, well, now because I left it on my pocket all this time. But generally, I don't have to recharge it except once every 3 months or so, and you can get rechargeable AAAs. And so you can take a look at how bright it is. Not too bad, right? Like it's pretty. Here you go, TV land. There you go. Arrgh. So you can see how bright it is, right? And you can really pick up a lot of injuries. I can't tell you how many wounds I've picked up with just using this light source compared to everyone else's light source. I think the only people that carry something as bright as this is our neurosurgical colleagues who want to check the pupils really big and the big traumas. Otherwise, I think I carry the second brightest light. So in addition to this, it's not only helpful with diagnosis, it's also very therapeutic, I've found. So, you're very, very intoxicated patient with an alcohol level of 450, with a GCS of 6, I can take them up to a GCS of 7, 8, and 10, by looking in their eyes multiple times. And so it oftentimes can save you an intubation. So it's both diagnostic and therapeutic. Okay, how are the things? So specifically for the scalp, because the hair is in the way all the time, is, use your fingers to the best of your ability. So in our trauma resuscitations, when they're doing the secondary exam from head to toe, they're not in there looking in the hair very thoroughly. All they do is kind of get a general sense, and then they put their fingers over it, and they rake their fingers over the scalp in a methodical fashion so that you kind of feel the entire scalp, and you're looking for huge hills, hematomas, huge valleys for step-offs and fractures or lacerations, right? You just want to get a sense of what big things am I missing, and surprisingly, you can pick up a lot with your fingertips. All right, so now we found the lac. How do we close the laceration? The classic teaching is, let's staple it up and be done with it. They'll come with staple repair in 7 to 10 days. But isn't there a more elegant way to do this? Specifically in pediatric patients. I don't know how you are in terms of your child whispering skills. I am about average. And so I can get them after about 20 minutes to trust me, to do one staple. And then, so what happens after you get that first staple in? Yeah, all havoc. Everyone is crazy. You basically feel like this picture. And like no one's happy. There's no way you're going to get that second staple in any timely fashion. So if you really feel like you have to use staples, most pediatric scalp lacs, I find you could probably cover most with 2 staples. It's the double staple gun technique. And Dr. Ye is here again at the wrong time, at the wrong place, and so I took a photo. But you basically need an assistant. You line up the laceration. You put 2 staple guns lined up. It's not efficient use of resources, but trust me, it's worth it. You line it up perpendicular. You go 3, 2, 1, you fire. Unfortunately, the same outcomes in terms of the crying and the screaming, but now you are working on your dispo paperwork and potentially a lollipop to come back. You've already kind of saved yourself 30 minutes right there. So if you really need to, think about using 2 staple guns at the same time. But now the question is, do you really need staples in these folks? I got an email from Dr. Fowler over in the country of Turkey, and he goes, you guys in America are so barbaric. Why are you using staples? I don't understand. And they said, really, the standard of care in many parts of Europe is the hair apposition technique. Has anyone used this trick at all? Heard of this trick? Awesome. So more and more people are using this. It initially came out of the wilderness medicine literature, and it makes so much sense. I wish I'd invented this. But basically, what is a scalp laceration? Right? A scalp laceration is basically a laceration that comes pre-made with sutures. Right? Your hair, they're there, unless it's a scalping this way, but your hair is already there. It's already kind of tethered to the base. It's perfect. So why don't you just use that? So what you do is you grab about 3 to 5 strands on either side of the laceration of hair. You twirl it up, and then you spin it 360. right? More twirls are not better unless you want like 3 spikes coming out of your head at the end. So you just need 1 twirl of 360, and then you put a drop or 2 of the tissue adhesive, a generous drop, on the twisting point. And it's impressive how well this comes together. Don't tie a knot because the knot tends to unravel. And it's great for your homeless patients who you find like staples in 6 months later. Right, this is perfect. It requires no return visit. And so you'll see when you twirl this 360 and pull it tight, a laceration just zippers completely closed. It's impressively effective. And then at these 2 twisting points, right here, you put a couple of drops of the tissue adhesive, and you're done. You can, if you have long hair, you can even do a comb over, Donald Trump style, and no one even knows it's there. All right, so some cautions are that you want to avoid and potentially really long lacerations because they're slightly at higher risk for infection, and so it's a little hard to unravel all of this. Those that are grossly contaminated, actively bleeding, and those with significant wound tension. Otherwise, for the simple, uncomplicated scalp lax, this is perfect. Right? So the modified, quote-unquote, modified part of the hat trick, it just means to use, go back one, is actually to use Kelly clamps, instrument clamps here. And I find that this actually provides you a little bit better tensile strength, and it closes the wound just that much nicer. So if you grab 2 instrument clamps and do this trick, it requires an assistant to dab the tissue adhesives. This is an amazing way to close scalp lacerations. So the question is, can you do that on wet hair? So you mean if they come in with wet hair? Oh, I see. So let's say you anesthetize the wound, you've irrigated it, and it's kind of wet. You would try to dry it as much as you can, and honestly, by the time we get to them, we put a dry piece of gauze and we come back. It is sufficiently dry to keep this closed. Absolutely. And surprisingly, the tissue adhesive is so strong that they ask if they can take a shower, and I say in the first 24 hours, no, but if it gets a little bit of wet, it still sits fine. That's a good question. It kind of depends on your index of suspicion for the patient's pain threshold. And so, listen, I'm happy to numb you up, but, it's another 2 shots, or I can just try to wash it out and then glue this in place. So everyone has their own different preferences about whether they need a local anesthetic. Yeah, specifically for the pediatric patient, I've had better luck with no sub-Q lidocaine because I think the irrigation part doesn't really bother them as much as one would think. Yeah. Does anyone have a different experience about whether you want to use sub-Q lidocaine before irrigation in kids? I think everyone's got a slightly different threshold. I'm more on the side of let's try not to numb it up first and see how upset they get. And then we can kind of address that when we get to it. Okay, we're still on wound care. So this is a man who presents after being assaulted to the head, and you see an ear laceration that's going to need wound closure. How do you prevent the dreaded complication of the cauliflower ear? All right, the cauliflower ear comes up because there's a residual hematoma that erodes through the cartilage. Not very good. And the classic teaching here is, there's a couple. One is you can get impregnated, oil impregnated gauze, and you kind of wedge it into the crevices. And then you put a thick pad of gauze behind their ear, and then you kind of bandage everything down. That's one way you can do it. Another one, which is I find people are a little bit more aggressive, is you can get this really thick, rigid mesh-like material and actually suture through and through the entire ear to tack it down. I find this is a little bit aggressive, but it's another alternative. And then you put a dressing on it, and then you pressure dressing it down. But an alternative, what I found is, what do we have in our ED that's great at molding to the patient's structure, shape, right? Which is plaster. We have it for ortho. You can get these really skinny rolls of it, and you just, roll up like a little mini cigarette, and you dunk it in the water. You squeeze out the water and the air. You have this nice little roll. You pad it with a little bit of padding so that the plaster doesn't get completely stuck to the ear. And then you just kind of fit it to the patient's ear, right? And then you can actually kind of flip it under there. It fits really snugly. You get like a 4x4 gauze, and you cut it about halfway up. And when you cut it halfway, it turns into a V, right? And then the V will snug behind the ear. Now the question is, you're like, well, that makes sense. But what is the most difficult part of this whole procedure? It's like, how do you get everything exactly. How do you get everything to stay where it is, right? And classically, we see this, right? You get gauze, and you do your darndest to either use a Kerlix, even better for an ACE wrap for a little bit more compression, right? But when you put this on, and you're like, okay, leave this pressure dressing on for at least 24, 48 hours, follow up with your ENT surgeon, and they're signing the discharge paperwork. They're walking down the hall towards the exit, and then what do you see? And then you're like, run for the door, man, run for the door. You're like, just go, go, go. And you're trying to get them out the door as fast as you can, but inevitably, even before they get the door, the gauze just, the ACE wrap just pops right on off. It makes sense. It's like, why would you wrap a round structure with the ACE bandage? It doesn't work. So what can you do alternatively is essentially what you want is a compressive kind of a beanie hat, right? Something you just pull down, secure it in place so it won't pop off up top. And so why don't you create a beanie hat? So we already talked about the tubular gauze, right, that we use for finger dressing. And like I mentioned, if you stretch it enough, it'll stretch over your head as well. So all you do is you grab like maybe 1.5 feet of this tubular gauze. You tie a knot on one end, and that end is going to sit at the vertex of the head. Then you cut it about halfway up. So these are going to be the tails that sit around the sides of your face. You can open it wide open, fit it right over your head. It's one of our residents who we are unleashing into the world, unfortunately. And he's pulling it over his head. I'm not sure what he's doing in that stroke alert room, but he's pulling it over there, and then you can tie a nice little ribbon at the bottom. You can cut them short. And if you look to the side, you can see how it keeps everything in place. There's no risk of this coming off the head. And so in that same patient who we put the plaster splint on and the gauze behind the ear, this is the same patient. We then put like a stack of 4x4s. Beanie hat goes on. Done. All right, so this is a great way of securing this. I've always wondered about this up until like about a year ago on how to keep this in place, and now I finally have the answer. All right, we're doing okay. Let's move on to orthopedics. I think it's another bread and butter topic that we have in our ED. So a woman who comes in with a second metacarpal fracture, you can see here in the x-ray, and the classic teaching is, right, you want to immobilize one joint distal, one joint proximal, and so that means you want to immobilize the MCP, you want to immobilize the wrist. And to do that, a volar wrist splint is the classic splint to put on. But when you put these on, have you noticed you just want to immobilize the second metacarpal? You kind of took out number 4 and 5 there, so you need 4 and 5 to help you grip things. But if you immobilize those, it really kind of gets in the way of your day-to-day activity. So, what's a little bit more stylistically better way to splint this? Is something called a radial gutter splint. A radial gutter splint is basically the mirror image of the ulnar gutter splint that we all know for the 4th and 5th metacarpal injuries. All right, so take a look at this video. This is a prefabricated splint. You can use a 3 or 4 inch depending on the size of the patient's hand. You basically cut it about longitudinally, so it reaches from the fingertips to the snuff box. You fold it in half, and basically you leave your thumb and your 4th and 5th fingers free, and it provides a sandwich of the volar and the radial aspect of the 2nd and 3rd metacarpal. And look at that, number 4 and 5 are free to help you grip things. It actually provides a little bit better stability because you have volar and a volar and a dorsal piece of the splint to immobilize the metacarpals. All right, so think about the radial gutter splint. The only time I've heard about this trick is some in orthopedics, in the orthopedics literature, and I don't know why it's not becoming more mainstream, but I find that this is a great splint to know about. How about this fracture? You see a distal radius fracture. Traditional, you do a sugar tongue splint, right? You want to mobilize the elbow, you want to mobilize the wrist, and this is the sugar tongue splint that you come up with. But if you put these on yourselves, I don't know if you've noticed, but do you notice that sometimes you get a little bit of scalloping here at the elbow, and it just doesn't fit great, and then when you wrap it, it still kind of bulges out a little bit. I don't know. It's these little things that bug me in the ED. I don't know why, and so I was like, I am going to figure this problem out. And so one trick is because it's scalloped, it just means because there's redundant splint at the bottom, right, at the elbow. So why don't you cut a little slit here, cut a little slit, and that way these can provide this. These can fold over each other a little bit better at the elbow, so it's not scalloped, and then you can wrap it a little bit nicer. Alternatively, there is the reverse sugar tongue splint. Why does the U of the splint have to be at the elbow? why can't it be up at the hand? Right? So to do this, you grab your prefabricated splint here. You want to cut it almost entirely through the entire splint. You leave a little bit of web padding here holding it together. You cut through the entire fiberglass, though. There's just a little piece of padding holding it together, and it sits in the patient's first web space. And now what you can do is you can control these tails individually and snugly put them where they need to be so there's no scalloping, and then you can wrap it. Also very prevalent in the ortho literature, I think it should become more mainstream, is the reverse sugar tong splint. All right, more ortho. This is a common thing we see in RED, right, which is an anterior shoulder dislocation. And when these pop out, patients, in quite a large degree of discomfort. And I would say like 90% of my colleagues, do you guys do all, actually, I should poll you guys, do you guys do procedural sedation for these? You guys knock them all out. I did until about maybe like 6 months ago. I knocked them on, Brevitol, Propofol, whatever you got. Have them relax so you can put this back in. Actually, so it sounds like, at least like 60% of you do this as well. And, I ran into a colleague of mine, Mike Stone. He said, I think he's still in Highland right now, but he's one of our ultrasound gurus, who says, ever since I use ultrasound-guided intra-articular shoulder blocks, I have never procedurally sedated anyone for a shoulder dislocation. You inject, 5 minutes, boom, it goes in. I think he actually had some races with other faculty. They had 2 shoulder dislocations to see who could get it done faster. But it's apparently a very quick way of getting great pain control so you can reduce the shoulder. And it frees up a nurse, right? So you don't have to do one-on-one care with procedural sedation. So here's how it works. I know you guys had the ultrasound workshop on the kind of the bread and butter things we use it for, and I'm going to review throughout this talk kind of more of the cool tricks you can do with ultrasound. And this is one of them. So in this case, you need to use not the linear probe, but the abdominal probe. The reason is you want to be able to transduce through a thicker layer of tissue. Because in shoulder dislocations, which this person doesn't have, he's a demo, but the humeral head won't be here, it's going to be way over here. So you need a transducer that will be able to capture that degree of depth. So an abdominal probe is great for this. Now let's show you, he was kind enough to send me a movie to share with you guys, which is, let me show you what a normal is, and then let me show you what abnormal is. So this is a normal case. See, he's rotating his shoulder. Here we go. Here's the scapula, bright white. Here's the humeral head rotating when you rotate the shoulder. And here's the rotator cuff kind of riding along with that. Same thing. Scapula. This is the glenoid rim right here. Let me show you what is a shoulder dislocation. Scapula. Here's that rotator cuff. Here's the edge of the humeral head, and then there's all this schmutz in between, right? It just doesn't, more normals you see, so I would encourage you actually ultrasound the other person's shoulder and kind of compare. And then you come, again, in plane from the lateral end. Here comes the needle, the bright white. And then you'll see here, in about like 3 seconds here, you'll see a flash of bright white, which is the anesthetic going into the hematoma space. 3, 2, 1. Boom, right? And that is all of your anesthetic into the intra-articular joint, right? Some tips that Mike mentioned is that you gotta use a spinal needle for this. Because, many years past, I used to, you see all the literature about how great intra-articular blocks are, and so, I kept on wanting to try, I kept on trying it, and I'm like, it doesn't work that great for me. And what I think is going on now in retrospect is that my needle's not long enough. So he uses a spinal needle. If you use a regular needle to inject, you are not even close to the shoulder joint. You got to use a long needle, and then you got to get a good flash of blood back, which is the hemarthrosis, and then you'll know in the right space, and then you can inject 10 to 20 cc's of the anesthetic. Right? So has anyone tried this at all? I'm curious. This is still kind of a fairly new wave thing to do. Yeah? Any luck with this? Pretty good luck. Yeah, I'm a believer. I mean, Mike says he uses this all the time for his shoulder dislocations, and I mean, it's hard to, refute this very convincing ultrasound that you're in the right space. So give this a try next time. I think the more normals you see, the more obvious that what abnormals look like and what you want to actually aim for. So just another cool trick to think about. But unfortunately, let's say this is the 1 in 100 cases that can't get. You can't reduce it. You're going to need to do propofol. And you're like, let's do it. And have you noticed when you give propofol that it burns quite a bit? Some patients are like, before they completely pass out. This should be fine, but, if you can anticipatorily anticipate, how to minimize that pain, I think it's a nice style point. So there's actually a bunch of great literature out there, and there's one meta-analysis that was done in British Medical Journal last year, I think, that said there are two things to do, right? One of two things. One, make sure the IV is in the antecubital fossa and not in the hand. You need a much bigger IV vein caliber to minimize the amount of pain going in. So if you anticipate using propofol, try not to put an IV near the hand and the wrist. That's an easy fix. But for instance, if the person's a bad IV access candidate and all you can get is the hand, then what? Right? Has anyone primed the line with lidocaine sometimes? Yeah. Any luck with that? Routine. Yeah. So yeah, perfect. So I think it's great if you routinely do this. I think a lot of people forget about it, and they're like, after the patient complains of pain and falls asleep, and you're like, I should have primed the line, huh? So if you think about it ahead of time, that would be great. And the way they teach this is, lidocaine should be given about 0.5 mg per kg, so let's say 35 milligrams. You got to put a tight tourniquet up, more proximally, and then you inject this lidocaine and let it sit around for about a minute, right? So it anesthetizes the track of the vein, and then you let go of the tourniquet, and then you push the propofol. It's an extra minute of time, but I think, again, this is all about style points in emergency medicine, and this seems like a quick one to incorporate into your practice. So think about priming with lidocaine. All right, other dislocations. So we got the shoulder, we got different fractures. How about hip dislocations? I find that these are just entertaining to no end. But so anterior hip dislocation, how do you relocate hips? Right? When I was trained, we used to, I don't know if you guys still do this, but we used to climb on the bed, right? This is only one of the few cases where you actually get to climb on the bed and you're actually holding onto a leg. And inevitably, it's like one of the winning slot machines here. Like coins fall out of the provider, right? You're like, yay, there's all these coins coming out. It's kind of like Vegas. But there's got to be a better way than getting on a bed and losing all your coins and pens from your pocket. And the trick is, so here's one. This is, not good. You can imagine the person falling. Is the Captain Morgan technique. Have you guys heard of this? It's kind of hilarious. It really does. That's the right position. And Greg Hendy, who's a colleague of mine over in Fresno, came up with this, and he published it and got a lot of press, actually. And it's great. So the idea is, instead of pulling axial traction directly into the air by standing on the bed, why don't you use different levers and fulcrums to kind of do the same thing? So what you do is you elevate one leg and you prop your foot on a hard surface. Here's the hard surface here, because what you're going to eventually do is plantar flex this foot, and when you plantar flex, you're actually going to pull axial traction up. Right? So you wedge this under the patient's knee in the popliteal fossa. You have one hand near the ankle, but you also want one hand in the popliteal fossa. And what happens is when you plantar flex the leg, your hand will also pull up, and it will, seesaw this back into place, and it will basically pull the femur back into place. And so I'm like, really? Do you think this will really work? And YouTube has everything. And so I did a quick YouTube search, and I found two great ones. So if you have a little free time, just Google Captain Morgan technique, and a bunch of these pop up. These are probably the two best ones. I clipped them short for time's sake. Here's one, somewhere in Southeast Asia, I think they were doing in the OR. Okay, here's the provider's leg, standing on a hard surface of the gurney. He's not really using the hand in the appropriate, look at that. Plantar flex. You see his right hand. He wants to put it under there, but he hasn't quite figured it out. One hand's pulling down, boom, and then it falls into place, right? And then you kind of do a range of motion check. So that's one way. Ideally, the hand should have been in the popliteal fossa, but still a great example of the Captain Morgan technique. Look at another example. Right? Knee is propped up. So you want to, instead of overhanding it with this hand, you want to underhand it. There you go. Popliteal fossa. Pull up. Boom. Right in. Right? No need to climb on the bed. It takes just a little bit of force and using all the right vectors of physics, putting it in the right place, and it pops it into place. A variation of this trick, which my friend Fred Wu mentioned to me, is he says, you know what, actually, there's a thing called a Whistler technique. I don't think I'm strong enough for this, but I think if you're kind of strong enough for this, you actually don't even need to put the leg up. What you do is you create a bridge with your arm, and it's stabilized by the patient's other knee, and then you basically try to pull up with your forearm. I'm not that strong. But it's another technique. It's an idea of how to create axial traction of the femur without climbing on the bed. That's an excellent point. So the comment was, so Greg Hendy has put a couple of comments out there, and he says, one tip to improve your ability to do this is have the patient actually get back on the spine board, so you're on a rigid board, right, so that your foot can actually lever against it. But the other reason is there's a lap belt you can put over them to stabilize the pelvis so it's not torquing out of the way. So this allows you to stabilize the pelvis and kind of let your foot lever up so you can pull axial traction. But that's a great point. You might think about using the spine board, and it sounds like it made a great difference in your N of 1. But hey, that's 100%. All right, pediatrics. So a little preview for tomorrow. There's some great tricks in pediatrics. And for instance, this is a 5-year-old boy. He comes in with a supracondylar fracture. You know this is a supracondylar, by the way, because how do you know? Besides the yellow line, here's the capitellum, right? In a line, the anterohumeral line, which is drawn along the anterior surface of the humerus. It should bisect the capitellum, so this is a slightly displaced supracondylar fracture. But what do you do for pain control? Notoriously in the pediatric population, we undertreat pain, right? If we have a fracture in an adult patient, Percocet, oxycodone, what do you give them? A lot of opiates. And a kid that gets it, you get like ibuprofen, really? So there's this great study that came out in Annals that says, you know what, we undertreat people and we should be giving more. But I hate to start an IV in a kid because it's also very traumatic. So we have intranasal fentanyl, right? We all know the nose is very vascular. That's why the paramedics give like intranasal Narcan, intranasal all sorts of things. But intranasal fentanyl has been shown to be a very safe option for pain control in kids. 1.5 micrograms per kilo. You can redose it a few times every 5 minutes. It's been shown. They did all of these risk studies and it said, you know what, there's very low risk of respiratory depression. It's very safe. Is anyone using this at all for their patients? The intranasal fentanyl? A lot of times you are held up by the fact that you don't have the atomizers. They're apparently really cheap to purchase in bulk. I heard they were like $1 or $2, but they're great. You just kind of wedge it into the nose and you kind of give a squirt. This is actually, I've seen in Children's Oakland, I heard they're actually doing a mini procedural sedation using this, but using intranasal Versed as well. So I think the intranasal route is increasingly going to be a much more popular route for administration of medications in kids. Keep a lookout for it. Advocate for it in your hospital. If you see a lot of kids, this is amazing. Yeah, I thought about that. Before we got intranasal about 2 years ago, I tried to make stuff, I made like a 22-gauge angiocatheter on a syringe, and I tried to squirt it up there. It doesn't have as much of a good effect in that you really needed to atomize in the back. The question was, are there any other alternatives to intranasal if you don't have the atomizer? And it's unfortunate. I wish, maybe I should invent one. Maybe, I don't know. None of the ways I tried to rig something up in the ED tended to work as well. So yeah, I'll keep on the lookout. But they're apparently pretty cheap to make or to purchase. So you might look into kind of buying a box of it in your ED. Have you tried nebulizing? I have not tried nebulizing. We recently went to electronic ordering of medications, and I am not sure if the pharmacist would flip out. I don't know about, have you tried nebulizing any fentanyl before? Yes on lidocaine for like NG tubes. I find that they work really well. It numbs up the throat and the nose. Narcan, I think we're going to talk about in just a little bit. As another option. But in terms of specifically for pain control and nebulizers, I haven't tried that at all. Would it not work in theory? Yeah, how do you titrate that? I don't know actually. How would you titrate it? How would you dose it? I'm not sure. I mean, let me know how it goes, though, yeah? This is a 3-year-old girl, presents with nursemaid's elbow. A very common presentation in the ED, right? It's when the radial head kind of slips out of the annular ligament, and it's a very easy reduction process. Very rarely do they need any pain medications because you can pop it back in place. How do you pop it back in place? Right? Yeah, I see some of you guys doing. So the traditional method is the supination, elbow flexion. And so a lot of times, you're saying, hey, how you doing? You're examining the hand and the wrist, and all of a sudden you go, boop, and then you can put it right back in. Interestingly, I know this works well for a lot of us. There was actually a recent Cochrane analysis this year, actually, that said a slightly more successful technique is the hyperpronation technique. So you have their elbow already in 90 degrees, and what you basically do is say, hey, how you doing? And you go, crank, and you just turn a little bit more, and it pops right in when you hyperpronate the patient's arm. This is a great trick. I've done this now consistently, probably in the past 12 months or so, and every time it really does just pop right in very easily. Is anyone using the hyperpronation technique? I think a lot of us know that exists, and I think this is just finally the evidence out there that shows that, this has a slightly better success rate than the other route. So it looks like a lot of you guys are doing that already. All right, but before you even get close enough to her, she's already kind of terrified. You can't even get within like 5 feet of her. What are your child whispering techniques? I think this one is people get really creative with this. And I find that the new generation, they're all about technology, right? They are great with iPhones, iPads, anything that comes in their direction. They're like, they're starting to manipulate things. So here's one thing I have. There's a free iPhone app. It's sponsored by one of the societies of ophthalmology out there. It's called the Eye Handbook app. Free. It's a little busy in there. You got to scroll through some of the commercials in there. But EHB is the app. And when you turn it on, let me show you what it shows. There's this thing called PEDS fixation targets. Because you can imagine an ophtho, you're going to need a kid to keep their eyes still to do a good eye exam. And they have these things called PEDS fixation targets. So basically, I start playing these on my phone, and then slowly the patient will just come towards me because they just can't help it. So here's what these PEDS fixation targets look like. I think the audio should hopefully be on. You're like, That one's a little scary. Yeah. This one's disturbing, actually. I don't understand the whole appeal of that. And then the happy one. So anyway, there's a lot of different distractors out there, and I find that I find the PEDS residents get really fixated by this. I mean, and I'm like, what are you doing? Pay attention to the kid. And so, like, the PEDS residents are coming in, the kids are coming in. I'm like, everyone's just mesmerized by this thing. So it's very effective, apparently, for all ages. On the same app, there's also 2 free movies. They contract. Well, actually, there's a 3D animation company that looks very like professional Pixar-like, and they basically created these 10-minute movies to help basically fixate the kid on this movie. And just based on anecdotal experience, the one with the cheese works a little better than the one with the robot. I don't know why, but it's just basically a mouse following a cheese around for 10 minutes, and it's just enough time where you can get a little lido in and a little bit of suturing done. And they really do gravitate to these movies. So, again, they're free. If you got them on your iPhone or your iPad, they are invaluable. So think about this as a way of helping to build rapport. What are other good apps in pediatrics? There's this one. There's more and more so. There, the Candle Flame app. These are free. I think it's now also called Free Candle. There's a bunch of candle stuff. And, you can't get a kid to blow on a peak flow meter for asthma, can you? It's very difficult. So what I do is, this is my rough gauge of a peak flow meter. And the nice thing about these phones is that, here we go, you can tilt it and the flame tilts with you, the wax drips if you leave it on too long, and you keep about maybe like 6 feet away from the patient. You're like, look, I got a birthday candle for you. You blow at it and then it goes out. And then you try it maybe like 6 inches away a couple of times, and you get a sense of like how forceful the breathing is. It's very subjective, but it kind of gives me a sense of like, do I feel comfortable letting this patient go without any other objective measure? So I use this. It's a great peak flow meter for me. It's entertaining, and they always remember their visit with the birthday candle. And then this one, actually, one of my residents, Susan Brim, actually has a little girl, and she's like, what works great for my little girl is this, Balloonimals. This is also a free app. You can upgrade to a pro version, but this is the one it comes with. Oh, sound on, perfect. And again, free, and all you do is you have the patient blow into the mic, shake it up. When it's all blown up, shake it up again, and it forms a monster. And then you look at it, and then you can blow it up. This one also, the residents really gravitate to also. So, you can use it for all ages. It's great. I mean, it takes quite a bit of force to blow this balloon up on the screen. Unfortunately, you kind of have to massively wipe down your phone after you're done. But it's a great way of getting a good sense of their peak flow. So that was Balloonimals. All right, head and neck. How are we doing on time? We're doing very good. Oh, wow. So this is a 35-year-old guy that comes in with eye pain after being splashed with some industrial bleach. And you know what's in his future, right? You're going to need a visual acuity. There's a slit lamp in there. There's probably a Morgan lens and irrigation process that has to happen. So you're like, oh, this is going to be a bit of a stay here. So first of all, you try to put some proparacaine in this gentleman's eye to kind of start numbing him up, making him more comfortable. But you realize that, this is going to be a really long stay because he can't even tolerate the drops. You know how some people are really sensitive to drops who don't normally wear contact lenses, right? And so he's all over the place. So, instead of fighting him by prying open the eyes and dropping those drops in, why don't you just say, hey, you know what? Just close your eyes. And they're always like, close my eyes? I'm like, just close your eyes. And then look up, point your nose to the ceiling. And all you do is just put 3 to 4 drops of this in the medial canthus of the well. It slowly warms it up to skin temperature. And then when they open their eyelids a little bit, it slides right in. There's no need to fight this. It will get in there. So use the medial canthus, drop it in there. Don't, force it on. So that's an easy way to slide these drops in. Now you try to do a visual acuity, and, he's already squinting. He can't get around very well. And same thing, there's an app for that. There really is. There's various eye charts out there that you can get a visual acuity from his room, from his gurney, so you don't have to parade him around the ED. And so you check a visual acuity, and this is generally done at about 4 feet away. And I thought, that is genius. What is 4 feet away, but just past the reach of the patient? Because it's always the patient that's got bloody fingers. He wants to touch your phone. You're like, what are you doing? So it's just out of reach that you can still get a visual acuity, but you keep your phone nice and clean. All right, so use the eye chart. It's a great tip. There's also another one that lets you scramble it if you think they're cheating for some reason. Anyway, but there's a couple out there. All right, now this patient for some reason does normally wear contacts, and it, doesn't have them with them, and you got a visual acuity of 2200 in both eyes. So you're like, well, is this from the chemical injury, or is this because he doesn't have his contacts in? How do you differentiate the two? Right? How do you know if this is a refractory error? Well, what you can do is, do you guys have these pinholes in your ED? Right? You could slide this down, you check your visual acuity through the pinholes. And the way these pinholes work is, right, when you have a blurry vision in your eye from refractory problems, it's because you have divergent light coming at your lens, and it doesn't quite get focused onto your retina, and you create what's called a blur circle. The image is a blur. But what a pinhole does is it gets rid of all of the tangential light and only lets in the parallel light, and then it very easily goes to the lens, and it forms a little pinpoint image in the back of on your retina, right? And when it does that, at the expense of making things a little dimmer, you get a very crisp picture if it's just a lens problem. All right, so when you put this on and this vision corrects completely, it means it's because his contacts are out. You put the pinhole in and it's still very blurry, it's potentially a structural injury. All right, and that's how we differentiate. It's a great tip. But for us, kind of with the finger applicators, these things are also missing in the ED all the time. I never know where they are, and they're always in the wrong zone all the time. So what you can do instead is just grab any kind of thick piece of paper, cardboard, index card, whatever you got, grab an 18-gauge needle, pop a couple of rows of holes, and you put it up to the patient's eye. It works just as well. Right? You only just want to block the tangential light coming at you. So this works very well instead of a pinhole, a fancy pinhole thing that you have. So now you've got a visual acuity, you've got, pain is under much better control, and you have these Morgan lenses that need to go in, and he just cannot tolerate these, which I find most people cannot tolerate these for too long with this cold saline running in their eyes, despite the proparacaine. So what I do now is I very rarely use these Morgan lenses, right? You know these Morgan lenses, right? This is like basically the contact lens that sits on the eye. and this end attaches to a bag of a tubing that goes to a saline bag, and then you just open the saline bag. So instead of this, I find that nasal cannulas are much better suited for this than even like providing oxygen. This is such the perfect equipment for this. And what you do is here's the IV bag. You spike it with the IV tubing. Here's the IV tubing. And the IV tubing it just needs to wedge right into the port of the nasal cannula that would normally sit into the oxygen port. And then here's the rest of the nasal cannula. And then here are these two little prongs that would sit right at the bridge of the nose, right? And then you open up the IV tubing and let her rip. And it basically directs saline and irrigation fluid right at the eyes. Like, this is so perfect. It's even better than for oxygen. It's two of them. It sits right on the bridge of the nose. It can't be more perfect. And patients can actually titrate the degree of discomfort they have, because all they need to do is just close their eyes for a few seconds, right? And then open them back up. An adjunct to this is actually you can inject 20 cc's of the 1% lidocaine into the IV bag, the 1 liter bag, and then have a very dilute solution, irrigation fluid, kind of bathe their eyes as well. So you can inject some lidocaine if you found that helps a little bit. So then when I gave this, I put this on the website a while ago, and someone who I collaborate with a lot over in Italy, she has a huge following in Italy, and she shares all of these tricks and also comes up with a lot of great tricks herself. And so her name's Gemma over in Italy, and she's like, you know what? I'm like, what? And she said, I was at the hairdresser's. And I go, oh, I like where this is going. I don't know where this is going, but I like where it's going. And she goes, I found a great trick for something as an adjunct you can use in irrigating eyes. I'm like, all right, let's hear it. So she goes, well, why can't we create a little basin that looks like in a hairdresser that you sit your head back in so that the rest of you doesn't really get wet? Right? Because normally when you do this irrigation, it's like a deluge of fluid all over the bed, and there's no way to keep them clean, and they're shivering by the time they get out. So she goes, why don't you create, everyone's got these little basins. In retrospect, I'd probably cut this a little bit more shallow, like more like that, so that you can capture more fluid in here, right? Because if it's this shallow, you're going to need to empty this bucket all the time. And so you cut it out, and then you rest their head in it, and then you open up the saline, and then you can collect all that fluid in and around their head and keep the rest of their body dry. So I'm like, oh, this is amazing. But then I go, you know what? I'm going to totally one-up you. We always try to one-up each other. And I'm like, you know what? You don't have to even empty the basin. You could actually stick a suction Yankauer in there, and then you just have to empty the bags every 2 liters or so on the wall, and you can leave their head in there. Because sometimes it takes 2, 4, 6 liters of irrigation fluid to get the job done. So you can use the suction Yankauer, and it keeps everything in a nice, clean, collected system. So there's just so many tricks and adjuncts you could keep on adding, but this is a great series of one of how they developed. All right, so now you're done irrigating, and you notice, the eyelids are getting a little bit swollen, and I really want to do a better eye exam, but you're having a hard time retracting the lids. How do you get the eyelids pried open, especially if you don't have those fancy eyelid retractors that the ophtho folks have? How do you retract it? There's a lot of different ways you can manually do it. Obviously, in someone who worry about a ruptured globe, you want to minimize that kind of direct pressure. But when you go to when you hear talks, actually not here, but you've seen those movie projectors that if you pull on it and the screen kind of rolls back up and there's a roll at the top, right, and the screen goes away. Why can't we use those same mechanics for the eye, right? Kind of like use something on the eyelid and roll it up. So here's the screen projector that I'm talking about. Why can't you do the same thing for the eye? So grab a Q-tip, rest it in their upper eyelid, and then you just rotate it, and it opens their eye, right? So I don't know if you've given this a try. I've tried this multiple times now with really swollen eyelids, and it just really does an amazing job. It just, a couple revolutions, and all that redundant tissue is out of the way, right? You don't need to rest it right on the eye. It's just right in that sulcus right above the orbit itself, and it rolls everything right up. Right, so think of this trick. It's great for also when you're doing a solo slit lamp exam. You know how people always have like really long lashes when you're trying to do a slit lamp and you just can't get under there? Just grab a Q-tip and you roll their eyelids up while you're doing the slit lamp. All right, these are the fancy eyelid retractors that they have in ophtho. Alternatively, if that doesn't work, you basically can create your own eyelid retractor. So obviously after you've applied enough proparacaine or anesthetic on the eye, you can bend a Q-tip so that it's got a little hook to it, and then very carefully, you probably don't need it on the lower lid, you can just retract with a finger, but the upper lid, you can slide it under the upper eyelid, and then you can gently pull up. This also works very well. It's obviously a different patient, but it works very well for looking at the orbit. And then moving down from the eye, we got tooth problems. And this is always a big challenge because a lot of times your dental surgeon, oral surgeon is not in the hospital, and they're like, well, you can take care of it, just send it to our clinic. But what do you do with, for instance, a tooth that gets avulsed, comes in, you appropriately put it in milk and get all the dirt off of there, and then you actually get it back in place so it looks right, it's not backwards, it's the right tooth, everything's fine. How do you get it to stay, right? Do you have arch bar wires in your ED? How do you guys keep it in place? Or do you just have them like bite on a piece of gauze and run to the dentist? I mean, what is actually your trick to keep it in place? I mean, we have the luxury of the oral surgeon will come in and put some arch bars in there. It's a tough one, right? So there's actually a great paper that came out in Annals by Hans Rosenberg in Ottawa. And interestingly, his brother is a dentist. And so the two of them wrote this paper together, which I thought, this is just genius, which is you have the N95 respirator mask in your ED, right? Those nasal bridges are just really thin metal pieces. They're perfect. They're just pliable enough so you can reshape it how you want it to be. So you tear that off. And then you basically, the tooth that it got avulsed was this one here. So you need a very, very dry field. And then you apply Dermabond on the bridge, the metal bridge, and then you gently kind of secure this in place. And after like maybe 2 minutes, it's going to dry, it's going to seal, and you're done. It's very, very well stabilized using this technique. And then when they get to the dentist, it's very easy to pry this off. Right? So think about using Dermabond and what tools you have in your ED, specifically the N95 nasal bridge, to help you basically splint a tooth in place. I thought that was a genius. I'm still waiting to use this trick as well. Very excited. Here's another one. Same thing. I think it's this tooth in here that came out, but you can use gauze to keep everything nice and dry above, and then you Dermabond it, and then you splint it. Great, great trick. All right, that's all I got on teeth, really. Here's another one. This is actually one of my favorite topics because there are so many great tricks in this single procedure alone, and that is a peritonsillar abscess drainage. I'm curious, do you guys drain your own abscesses in your ED? Not so much a cut, but maybe aspirate, right? A handful of you do this versus like ENT. I'm trying to get all of my colleagues to stop calling ENT for these because I think we can totally take care of this in the ED with just aspiration of the abscess, antibiotics and Decadron to go, and follow up. So this is a case of, you can see here, this is a right-sided peritonsillar abscess, kind of bulging right up at you. The uvulus deviated a little bit. And this is actually a pretty good view. Now, when you're actually trying to aspirate the abscess, very rarely do you get this amazing view of exactly where you're going, right? It's such a small space. This is more of what you see. You're like, I think I'm in there, and I'm just going to try to needle around and see what's going on, right? The syringe is totally obscuring your view of the mouth, because usually there's a little bit of trismus, too, so you're barely able to get the syringe in there. So there's got to be a much better way to do this. And, of course, there is. So you think about all of the equipment that you have and that you need. First of all, what do you need? You need a tongue depressor, right? You got to get the tongue out of the way. You need a good light source, like the LED light I showed, right? You're going to need a needle and a syringe, and you're going to need a suction yank power. So you do not have 4 hands, nor do you have an assistant who can kind of get in the way of your procedure, right? So how do you get all these things together is you got to start combining pieces of equipment that you have. So what is a light source and a tongue depressor together? It's a laryngoscope, right? So you have these intubating blades in your ED, so why don't you use them? So you can get like a Mach 3, sometimes a Mach 4, it works. And you basically, depress the tongue. You want to give the patient a lot of kind of viscous lidocaine or even nebulized lidocaine and numb up so that they don't have a gag reflex. And then you just pull down, and there's a direct light source exactly to where you need to be, right? So now you've combined the two products together in a great way to see the abscess. Now, another trick is, a bonus trick is, if you have a very cooperative patient, I actually have the patient hold the blade, or the handle of the blade. And it gives them something to do, and they also know exactly where their gag point is. Some people have it really early, some people have it really, have no gag at all. And they, sometimes they really want to help you out, because they're like, okay, I want to give the doc the best view I can. And sometimes they over crank, right? They pull down, you can almost see the tip of the retinoids, and you're like, sir, I don't need to see that far. You can lay it up just a wee bit. The epiglottis, I don't need to see. So they come up a little bit, and now you still have two hands free to do this procedure. So you've gotten the patient kind of to help you out. They feel invested. They don't have to feel as helpless. And now you have two hands to do your procedure. An alternative to this is, someone actually recently told me about this, is actually, this pelvic speculas, you can break them apart pretty easily. The top half just comes right off, right? And the bottom half actually is hooked up to a fiber optic light. And it's just like a Mac blade with a light source. Same idea, you can use either one. Now, so the problem with the spinal needle, so the idea is you want to get the syringe out of the patient's mouth, right? And in order to do that, you need to make your needle longer. Now, when you make your needle longer, what structures do you worry about hitting with a spinal needle? Right? You don't want to get an ABG. I don't think it's necessary. So you want to make sure you're in the right depth. You don't want to go too far and get the carotid. So what you can do is, these spinal needles, they come with a sheath over it. So you can cut about a 1.5 centimeter leading edge to it. You cut that tip off. And what you're left with is about 1.5 centimeters of the needle exposed. Hook this up to a syringe so that no matter how hard you push, you will only go a certain depth. Right? So this is a great kind of reassuring way to know you won't hit anything you shouldn't. But let's say you tried this. You did all these techniques. Everything went well. You did 3 pokes in the appropriate areas, and you're like, I still got no abscess out. Could I have predicted that this would have been a dry tap? And again, ultrasound to the rescue. I find that more and more of these cases where people are using, the intracavitary probe, which is traditionally used for, pelvic ultrasounds, but it's an intracavitary probe. It can go in the mouth, and you basically put it over the abscess area. And what you can find is if there's truly an abscess, you're going to see a hypoechoic irregular structure. And then if you're trying to figure out, well, is that the carotid? You can actually turn color flow on and find that the carotid is sitting right here. All right, so a lot of times, if you don't see this and you feel very comfortable with the ultrasound, you can say, listen, I'm not even going to poke a needle in this because you don't have an abscess. So think about using ultrasound as you become more and more proficient with using it for non-traditional purposes. All right, so let's say you do this technique, and you know how some of the syringes have little ring holes on them to allow you to aspirate a little easier? Let's say you don't have those. For instance, we don't really have those. How do you single-handedly aspirate while you're trying to do all of these procedures? And so some people, it's very difficult because the patient's sitting up, so you're kind of reaching up anyway, and you're at a weird angle. What you can do instead is, I gave this talk over at Stanford, and he goes, and so Nick, he came up, he's one of the residents there, he goes, listen, don't struggle with this, get an assistant, and you know how the butterfly tubing, there's the needle, there's the tubing, and then there's the syringe. So why can't you put in an IV tubing adapter between the spinal needle and the syringe? And so, you could do the same thing. So you have a spinal needle, you have a long tubing, you have the syringe that an assistant can manage. So as soon as you get to the sub-Q, all you have to worry about is putting the needle in the right place, and the assistant is holding back pressure on the syringe at the whole time, and you don't have to manipulate at a weird angle. Right? It just takes an extra little tubing to help you out. All right, how are we doing? We're doing okay? All right, it's a lot of things to kind of throwing a lot at you, but these are really my favorite tricks that I'm glad to share with you. These are also, by the way, yep, and then we will also actually you want to take a 5-minute break. I think there's a little snack back there, and we're going to switch tapes and restart in a few minutes. Perfect.